researcher at IMPRI, Impact and Policy Research Institute, Prabhav Evam Niti Anusandhan Sansthan, Nai Delhi. Extend my heartiest welcome to you all to IMPRI #Web Policy Talk. Today, we are here for a panel discussion on gendered impact of the catastrophic second wave of the COVID-19 pandemic, way forward towards combating the third wave in India. This discussion is part of our series, The State of Gender Equality, #Gender Gaps, organized by IMPRI Gender Impact Study Center. We are very grateful to have Professor Vibhuti Patel to chair this session. Ma'am is an eminent economist and feminist and former professor at Tata Institute of Social Sciences, Mumbai. Welcome, ma'am.
Thank you.
We are grateful to be joined by Dr. Swati Rane, Ms. Poonam Kathuria, Ms. Seema Kulkarni, Ms. Renu Khanna, Dr. Swarna Rajagopalan, and Dr. Soma K. Parthasarathi as panelists. With the permission of our chair, I would like to introduce our panelists for today.
Please go ahead.
Thank you, ma'am. Dr. Swati Rane is the CEO of SevaShakti Healthcare Consultancy. She is Vice President of Clinical Nursing Research Society and also core committee member of Jan Swasthya Abhiyan, Mumbai. Ms. Poonam Kathuria is Director at Swati, Society for Women's Action and Training Initiatives, Ahmedabad, Gujarat. Ms. Seema Kulkarni is a founding member at Society for Promoting Participative Ecosystem Management, Pune. Ms. Renu Khanna is a trustee at Sahaj, Vadodara. She is also a member at the Feminist Policy Collective. Dr. Swarna Rajagopalan is a managing trustee at the Prajnair Trust. She is also honorary director at Prajnair Initiatives for Peace, Justice and Security. Dr. Soma K. Parthasarathi is a national facilitation team member at Makam, which is the Mahila Kisan Adhikar Manch, India. I'd like to extend our warmest welcome to the panelists. I now invite Professor Vibhuti Patel, our chair, to give the opening remarks and invite our panelists for the session. Thank you, ma'am. Over to you.
Yeah. Good evening, everybody. I'm really honored to be in the panel, sharing the podium with all the veteran feminist and women's rights activists and practitioners in health field. This panel discussion on gendered impact of catastrophic second wave of COVID-19 pandemic, and also focusing on way forward towards combating the third wave, is very, very important. And I think gender implications have not been discussed except for Swarna Rajgopal had an internal meeting of our organization. We don't see much discourse on the gender concerns of the second wave of COVID pandemic. So during second wave of COVID pandemic, India has once again experienced an onslaught of human miseries. Coronavirus infection in the second wave is more ferocious, with death toll of 2.1 lakh in 6 weeks from 1st April to 15th of June. The situation is worse in Maharashtra, Karnataka, Tamil Nadu, Delhi, and Uttar Pradesh. We are hearing new terms such as COVID orphans and COVID widows. The discourse among sensitive policymakers revolves around devastation caused by commercialization of healthcare system and naked profiteering by private players versus the urgent need for social regulation to prevent financial exploitation of citizens in general and patients in particular. On the one hand, cheerleaders of management consultancy firms and global institutions of financial capital, they are aggressively advocating for private solution to all problems and the support the factors enabling commercialization. While the community-based organizations, public health practitioners, trade unions, farmers organizations, women's rights groups, human rights activists, gender economists are asking for universal health care, financial allocation of minimum 6% of GDP for public health concerns, bringing back 10 million girls in India, that means 1 crore girls in India, who have been thrown out of education system as a result of digital divide, food and nutrition security, but in the context of massive malnutrition that people from poverty groups are facing over the last 15 months, job opportunity for 40% of women in the workforce who are rendered unemployed over the last 15 months, as per the CMI data, recognition, reduction, and redistribution of care work by proactive efforts to challenge patriarchal gender norms based on male domination and subordination of women, and application of labor standards and state stipulated wages to ASHA workers and Anganwadi workers, personal protection equipment and health insurance to healthcare workers, and prevention of gender-based violence that has escalated exponentially due to social isolation imposed by killer virus. Development economists have prevailed upon global leaders to promote fiscal expansion for redistributive justice and global minimum tax of 15% for corporate profits. Today, all newspapers are talking about the consensus which the G7 countries had regarding the profit transnational corporation, multinational corporations, and giant corporation firms, which are reaping benefits even in the midst of this pandemic. So pandemic profiteers, they have been under radar of the social scientists and social activists. But it is only feminists and women's rights activists who are highlighting the need of gender responsive public policies to deal with intersectional marginalities based on caste, class, race, religion, ethnicity, and gender. Now, this war of ideas between votaries of neoliberalism and supporters of people before profit policy has defined public discourse globally, nationally, and locally. During the first wave, these issues were getting attention in the mainstream media. Moreover, the food security of a large majority of masses and dehumanization of migrant workers were major concerns. While in the second wave, focus is on oxygen concentrator, vaccination, ventilator, and building COVID center under chaotic, arbitrary, and rent-seeking behavior of service providers, both of the public sector as well as private sector healthcare. Now, the first wave witnessed massive dislocation of urban areas, while in second wave, the coronavirus has captured the rural areas where healthcare facilities are scarce as well as ill-equipped. Gender-based violence has taken varied forms in terms of domestic violence, trafficking, forced marriages, forced labor, child labor, sexual violence, online sexual harassment, and superstition about Corona Mai. So temples for Corona Mai are created and women are asked to worship and please appease the Corona, Mother Corona, who is so angry with the community. From 1st April 2021, four labor codes of industrial relations, wages, social security, occupational health safety, and working condition have been imposed. There is hardly any media coverage on implications of these on women workers in all sectors of the economy. Three farm laws, the Farmers Produce, Trade, Commerce and Promotion Facilitation Act 2020, Farmers Empowerment and Protection Agreement of Price Insurance and Farm Service Act 2020 and Essential Commodities Amendments Act 2020 have been opposed by farmers' organization, and agitation is continuing for the last 9 months. Women farmers have played crucial role in this agitation. To discuss these multiple and cross-cutting issues, we have this panel discussion that includes committed, gender-sensitive, and experienced feminist and health activists working with nurses, farmers, industrial workers, urban, rural, and tribal communities, civil society organizations, and professional bodies in various parts of India. As per the Indian Medical Association statement, 594 doctors have lost their lives. I mean, these are the doctors who are registered under IMA during just 6 weeks of 1st April to 15th May. Even more nurses, ASHA workers, Anganwadi workers, sanitation workers have lost their lives, about which there is hardly any empathy displayed by the state. Women have not had equal say in the pandemic decision making at global and national level. Even the UN has admitted that. Now, it is in this context that I would first like to ask Ms. Renu Khanna, trustee of Sahaj, that what is the overarching concern in the public health discourse? And right at in terms of the macro policy level, at a meso and a micro level.
Thanks
over
a lot.
Over to Ms.
Thank you.
Khanna. Yeah.
Thanks a lot. And if I may have the slides, please. Yeah. So I was asked to speak on the public health response to the second wave COVID-19 pandemic. And what I have done is that I am looking at issues using a case study of maternal health. So I'm looking at, next slide, please.
Yeah.
I'm looking at public health, but taking the case study of maternal health, because I think what has happened in the second wave has really, in a very drastic way, affected maternal health. Not that it hadn't in the first wave. First wave was bad enough, but as I'll just show you, the second wave has been extremely shocking, and the implications are very serious for the future, building back better, as they say. So what I'm going to be talking about is the social determinants affecting maternal health, and many of these are going to be covered by my friends on the panel. So I'm just doing a very broad sweep, looking at maternal health issues in the second wave, and then looking at what can be some of the responses to build back better. Next slide, please. So what have been the social determinants affecting households? As many of us know, um, basically food insecurity and livelihoods insecurity has been a major factor through the first wave. And this compilation of 76 food surveys, which were reviewed by Jean Reyes and colleagues, has pulled together these findings from these surveys and point out to large-scale unemployment and massive income losses, not only in lockdown, but throughout 2020, and in fact, continuing up till now. And the figures are quite horrifying. 80% households affected by income reductions, and a quarter of these households had no income for 2 months, no income for 2 months of that year. Proportion of households eating less than before the lockdown was still 60% in October, December 2020, when things started opening up, compared to the 77% during lockdown period. So you can see that hunger is continuing well into the year. Migrants and informal workers between 35 to 66% eating less than 2 meals a day, less nutritious food, even in September, October 2020. Relief measures did help, but were patchy, and the reach was very fragmented and uneven. And what all of this led to was a lot of poverty, selling of assets, indebtedness, and depletion of physical and financial resources. And in that context, with the depletion comes the second wave. Next slide, please. And what were the effects on women? So a UN Women report said that in 2021, for every 100 men aged 25 to 30 years, 118 women would be in extreme poverty. So the gendered dimensions of poverty were very serious, or are very serious. And this UN Women report also states that this is going to increase to 130 by 2030, where the SDGs, the Sustainable Development Goals, and poverty is the first Sustainable Development Goal, is saying that there's going to be a reduction in poverty. So what's actually going to happen? A World Bank report says that in India, more than 12 million people will be driven to poverty because of the pandemic. And if you look at the figures of the women, the gendered impact, you can see how many women in absolute numbers are going to be poverty stricken. And the NFHS score is saying, and 5 also is putting this figure of about 55% women not using health services because of high out-of-pocket expenditure, because of gender bias in insurance schemes. And some of our friends have done some remarkable studies of how insurance schemes are leaving out women, excluding women in multiple ways. Let's have the next slide. So social determinants affecting maternal health. I've been talking about the general social determinants, but how have they affected maternal health since 2020? Of course, they've reduced nutrition for pregnant and lactating women. So there's been further depletion of their, resources, nutritional resources. We also know that the lockdown resulted in increased workload, including care work. We also know that it led to increased violence and mental health issues, stress and anxieties due to loss of livelihoods, reduced household incomes, fear of contracting COVID, anxiety about family members, COVID and their survival. And all of this has led to compromising their physical status. And it's in that situation that we have to look at pregnancy and look at maternal health care. Next slide, please. So how does COVID affect men and women differentially? The immediate and direct toll, the caseload and fatality is higher for men, but long-term impact is greater on women. A professor in the London School of Economics has said that what comes from being infected and what comes from being affected are different. So infection happens then, and the effect of that remains for much longer, as we'll see further. And from the Zika and Ebola outbreaks, we saw that more women died of obstetric complications than the infection itself. But women's deaths because of obstetric complications attracted much less attention than the disease itself. And in relation to COVID, pregnant women are in a state of altered immune response. And while pregnancy does not increase the risk of infection, once infected, the risk of severe disease is much higher, and 70% increased risk of death in pregnant women with COVID compared to pregnant women who are non-COVID. A Lancet review, very recent one, of 40 studies across 17 countries is saying that maternal deaths and stillbirths have risen by 33%. And much of this is because of disruption of services. And we saw that high-risk mothers are just not being tracked and traced in our old communities where we work. Maternal health services were absolutely not available in this entire period. And women also have a fear of attending health facilities because of the fear of getting infected. Next slide, please. So what's happened in the second wave? What do we see in the second wave? More women are getting infected than in the first wave. In the first wave, some figures, and these are figures from Telangana, but there are figures from other states also, 38.5% of the total cases, infected cases, COVID infected cases, were women compared to 34% women in the first wave. ICU admissions have increased. Women in the ICU earlier were 33%, and now 39% of ICU admissions are women. Women from younger age groups are more vulnerable this time around. And some of the gender reasons for these are that women are generally admitted later, especially those from rural areas. There are some reports, there's a whole range of stuff which is coming out. And this is one of them. Doctors in Ghaziabad and Noida were saying that there's a 10% increase in intrauterine fetal deaths, which means stillbirths, among COVID plus pregnant women than in otherwise healthy pregnancies. There's another report where this journalist is saying that she contacted 50 nursing homes across the country, and every single one refused to admit a COVID positive pregnant woman. And the reason was that the hospitals were afraid of getting COVID, or there were no resources, ICUs, oxygen specialists to treat high-risk patients. Maternity hospitals say, take her to the COVID hospital. COVID hospital says, you take her away and take her to the maternity hospital. So denial of services has been a huge issue in the second wave. Next slide, please. And I've been reading some heartrending accounts of pregnant doctors, women doctors. And I think many of you may have seen this video clip of a young doctor, woman, who was actually, before she died, she was She was saying, please take care of yourself and, follow all the,
No.
yeah, all the right behaviors. There was yet another doctor who was writing, she's pregnant, she's really scared, and she's fleeing for the vaccine. She's saying, give me the vaccine, but the protocols in the country are refusing vaccine to pregnant women because there haven't been any clinical trials done on them. Doctors are reporting dilemmas. Should we do a C-sec on a COVID positive pregnant woman because her oxygen levels will go down further? And then what will
Yes.
happen?
Yes.
And I'm sure Swati is going to be talking about quite a bit of this. Vaccinations, there are fewer women than men taking vaccines, and the COVID platform shows the figures. And what is coming out is that as the second wave became more furious, the desire to take vaccines went up and the gender gap increased. So they've given figures of the gender gap, and you can see that increasing as the virus is becoming more and more furious. There are gender reasons behind this. The policy prioritized workforce, the access to internet, digital divide. Women don't have the access to smartphones or digital devices to register on the COVID platform. Mobility is an issue. Vaccine hesitancy, some studies have been done, and they show that 61% more women are expressing fear compared to men. And pregnant women, as I've just said, were until recently out of the vaccine's priority list. And those who opted for the vaccine were denied. So next slide, please. So what can be some of the gendered responses to build back better? And I think the fundamental thing that we learned in the first wave was decentralization, coordinated decentralization, where people can mobilize, with community mobilization, but that they should have the resources. They should have the financial resources, but be able to take, informed decisions about what is required in their context. Integrate the pandemic response into primary health services, including a very strong mental health component. Strengthen the health and wellness centers. I think these have been a fantastic, sort of development, but I think much more needs to be happen in terms of strengthening them and staffing them properly with referral links that is required. One other lesson that we've learned is do not deploy maternal health staff to COVID pandemic disaster response, ensure continuity of reproductive health services, take vaccines to women, invest in communication to address fears and other local contextual hesitancy issues. Evidence protocols are required for vaccination for pregnant women with informed consent. Other countries are doing it. Foxy is very strongly suggesting this. Data systems need to be disaggregated by age, by sex, by comorbidities and health conditions, clear classification of deaths, transparent disclosure of RT-PCRs, of infections, of deaths and vaccines. All of this is required. And the last slide, please. And finally, I think, and this is a longer term measure, this is not immediate thing, but we have to begin on this immediately. Health systems have to invest in increasing leadership of women within the health workforce. We see that healthcare is delivered by women, but it's led by men. There are very few women in leadership and decision-making positions. So structural barriers that prevent women in the health workforce from reaching leadership positions have to be removed. Thank you. I will stop here now.
Yeah, thank you. There is also a response by the community worker, and they say, Mr. Santosh Sharma, we'll take it up in our Q&A session. But now I would like Poonam Kathuria madam to speak, to share her experiences on gender-based violence. Swati is an organization, has played a pivotal role over last 20 years to combat gender-based violence, and it is a network. They have networked with the women's groups all over Gujarat. Over to Poonam.
So thank you, Vibhuti. And Renu, thank you. It's always such a pleasure listening to you.
Very good.
Yes. And you somewhere also make my task easier. So when I'm focusing on gender-based violence, there was one kind, so gender-based violence on a broad spectrum of things. Okay, I need to
share the PPT. Yeah.
No, I'm not sharing screen.
Okay.
So when we are talking about, I'm constantly seeing you, so that's sort of distracting me.
So what should I do?
Nothing is that. One second.
Because the video is on and it's focusing on screen.
No, that's fine. Just that for a minute I thought, was I audible or not?
So we can't.
So, the first wave and the second wave, there are very stark differences, and I think all of us know about it. But when we talk about gender-based violence, I talk of it as a broad spectrum. In the first phase, obviously, gender-based violence, the focus was very, very much a lot of news about domestic violence, doubling of domestic violence abuse because women were with their perpetrators at home. And you know what, the migrant workers women face came out in a big way. But the second wave obviously is very different. And we are talking of not just the first wave, second kind of gender-based violence, but we are seeing other forms of gender-based violence. And that's what I will be kind of focusing on. My focus will also be on rural areas. That's where we work in. And I think that's where we also see that in the second wave, the pandemic has largely moved into rural areas where the health facilities are sparse and very distant. But just before I go into that, I just want to say that the idea that women will be discriminated against is not a rocket science. In a context like ours, it should be an assumption. And any aware government should proactively incorporate mitigation measures in all its approaches and policy directives. But there's many a slip between the cup and the lip. And when it comes to women, we somehow never get it. We have to always, if you look at it, there's a pattern about it. And mostly the onus of pointing this out to our so-called masculine male governments is also falling on we women. So I'm saying that as, if you notice, this is an all women panel, except for Dr. Arjun Kumar in that sense of the term. So in the second wave, the government's utter failure to respond to the pandemic has led to an unprecedented kind of a health calamity, not just in terms of COVID treatment, testing and vaccination, but in terms of regular health services of immunization, of ANC, contraception, TB or cancer treatment. So it's a wide spectrum. So there's been a complete health sector collapse. And the reason for that obviously is not in the current scenario. It is to do with the kind of investments that we have always been making. And in India, the health sector gets only 1% of the GDP, which is pitifully low. In that sense, it's something that we have neglected, and that's now coming back to us. In rural areas, like I said, health facilities are far. And an area that we do not have enough insight into is the impact of this lack of services on women and girls. One thing that we do know is that when anything becomes scarce, it becomes precious, it becomes coveted, and it becomes costly, it is always the men who will get it. So I'm saying it's from that perspective that I'm coming. So we recently decided to look deeper into this, and we did a small study to find out what is happening with women. Are they testing? Are they testing late? What happens when a woman tests positive? Is she fed adequately? Since she is the general caregiver, what is the quality of care given to her? And is the hospitalization done in time or not? So we spoke to ASHA workers, we spoke to ANMs, we spoke to Gram Panchayat members, and we spoke to some women whose family was affected or who themselves were also in the process infected by COVID-19. So some of our things. So vaccination. Like Renu has already mentioned, India has almost a 13% gap in immunization as of today. So there's a 1.7 crore gap of immunization between men and women. And this gap is going to go on and is going to increase, because till July or August, I think the vaccine shortage is going to continue. And given the rural context, this 1.7 crore is perhaps largely concentrated from rural areas. Uh, So that's whole one thing. And the other thing which I noticed was that what is happening. So we have data on men and women, but we don't have data on LGBT community. But my sense is that that's only 1.1%, or like I saw somewhere a figure of 35,000 others get taking vaccines in a population of, let's say, at least 10 lakhs that we have at least noted down. So that is there. The reason for women not taking vaccine, one which women themselves mentioned, was that what happens if I fall ill? Who will look after my family if I have fever? So even for those 2 or 3 days, obviously there's very little encouragement for from the family on this. So we had this case study of where there is woman who took vaccine on one day. 2 days later, she tested positive for COVID, and the doctor asked her to quarantine herself. Her farm was very far from the village, so she decided that I can quarantine myself on the farm and continue to work at the farm. Obviously, the family didn't notice her deteriorating situation or condition, and one evening she died in her sleep, and the entire village blamed the vaccine for her death. So I'm just saying things like this also lead to vaccine resistance. There are ideas about that vaccine pregnant women should not take because it leads to abortion, and men should not take because they may become, it can lead to infertility in men. So those are the kind of things. And of course, the social media is galore. When we looked at is she looked after, this is my own colleague Pramila, who told us this story about how her husband tested positive and Pramila was looking after him and everything was all right. And 5 days later, Pramila tested positive. And immediately her father-in-law called up Pramila's father and said, "Your daughter has tested positive. What should we do?" And of course, they were sent to another house now, and where Pramila continued to look after her husband. And of course, she herself was tested positive, was also in the process. I mean, so there was no one looking after her. She was looking after herself and her husband. That's the kind of caregiving. In another case, we came across this woman, this Asha worker told me that so this person tests positive and the doctor says she should be hospitalized in a hospital which is 40 kilometers away. The family did not listen to her. They took her home, and in 10 days, she died. And the same Asha worker then told us the story about how the same family spent 10,000 per day in a private hospital for their another son. So that's the kind of looking after that women are getting in terms of care for themselves. In terms of reproductive health, uh, there was this case of this woman again who died, where her father-in-law had died, and so she had not been fed for the last 4 days properly. Asha worker, when she tried the oximeter on her, her oxygen level was 90. The Asha told the family to shift her to a hospital. They did not do that. Asha shifted her to a hospital where she died. She was 5 months of pregnancy. She died in an ICU. So, and then of course we have anecdotal evidence of Asha workers talking about miscarriages. So she says, इस साल बहुत सारे ज़्यादा miscarriages हैं. Like she said, this time I have had 3 miscarriages compared to none in last year. So that's where the nutrition. But Renu has also, I think somewhere else also mentioned about how there have been unwanted pregnancies and then there have been risky abortions by women. So I think that data in some other space I've also heard. In terms of mobility, mobility not just for the vaccine, but Pramila, for example, because of the lockdown, there was no transport from her village, and she had to quit her job because of that. So women are falling out of wage employment because of that. We were also told of a story. What happens in villages is that you don't have enough public transport. So people rely on private chakras and small vehicles. Moment there is a lockdown, people are not commuting to town for work. So that means the private transport stops. And that is where, so she tells us the story of how she saw a woman standing waiting at the road, waiting for a private vehicle to come because her child was unwell. And 2 hours later, she said, now the hospital will be closed and I'll come back in the evening and wait for another vehicle. So the way it impacts women's mobility in rural areas is going to be also very different. In terms of, we also did a small dipstick study on deaths during COVID. This was a 25 village study where, so obviously there's a huge amount of fudging of data or not, or of hiding data. In our case, in these 24 villages, population was about 37,000. And we found that there were 20 COVID deaths, but there were 187 total deaths in those 2 months. And the rest were mostly suspected COVID deaths. We also looked at the fact that 30% were women and 70% were men. But again, I think we are talking about infected and affected. So when women lost livelihoods, but women, when men die, they lose lives, but but women lose, so women lose much more in the whole process. So women have started facing difficulties of how to register your name in the land. Suddenly there's been a death in the family. How do I cope up? So suddenly we have 187 widows in those 84 villages. And how are they coping up? So we are doing another study on that. And I think people are talking of orphans, but we also need to talk about the high number of women who have lost their main bread earner. And it also means like what happens to their name in the land? Are they being provided for by the rest of the family? Will they be inherited? Will they be disinherited? And stuff like that. So that's the other area of concern and cause for violence for women. If I have time, I can come up with my recommendations.
Vibhuti ma'am, please unmute.
Hello, can we take it in the way forward second round where you will get 5 minutes?
I will, then I'm okay with that. Otherwise, I have a fairly,
because we have a second round. Thank you.
Thank you so much.
Yeah.
I end
So
here.
I think both the previous speakers also highlighted that how the rural areas have been affected more in the second wave. So I turn to Dr. Seema Kulkarni, who is working in the SOPPECOM, and what are your experiences at the ground level? Hello, Dr. Seema Kulkarni. Are you there?
Seema ma'am is here.
Yes. Sorry.
Yeah.
Is the video not working?
Yeah.
No, it's working.
Please go ahead.
Okay.
Yeah, thankfully it's working. Yeah, thanks Vibhuti, thanks Arjunji for this opportunity. And I think I'm just going to take it forward because already Poonamji and Renu have, I think, sort of laid out the key issues that women are facing. So I would focus on women farmers' issues. And this is, of course, my learning and understanding of being part of Mahila Kisan Adhikar Manch, which is Maqam. And these are a series of meetings that we've had in Maharashtra and also, of course, nationally in the first wave. But a constant dialogue with women farmers, both by way of trying to understand the key issues, but also trying to extend support and how a relief program could also then create pathways for reform and restructuring. So I would try and sort of look at women farmers. And when I say women farmers, it's an understanding that Maqam believes in, where we look at women engaged in wage labor, forest workers, livestock workers, and all others engaged in agriculture and allied activities. So just quickly to talk about, the comparisons in the first and the second wave. I think there were some similarities, but there were some very distinctly different issues that also came to light. Of course, the first wave was very much, very urban centered in that sense. So for the rural areas, it was the lockdown that created much of the problem rather than the illness itself. So I think the problems that women farmers discussed in the first phase were more because of the lockdown. So markets were closed, mobility was completely restricted, and women farmers who had harvested their produce were not able to take it to the markets, local markets, which are very critical for single women farmers, where they sell their produce, small volume of produce, but these markets were completely restricted, and therefore they were not able to sell their produce. The second important thing that came up in the first wave was with reference also to saturation of local markets. So, vegetables and all the perishables that women, had as produce, there was a limit to how much could be absorbed in their own villages or in the neighboring villages. So that also meant a lot of destruction of the produce, and that created a very, very deep-seated economic impact. Now, harvesting was another area that women farmers spoke about, and that's also something which is part of the larger structural inequities. You know, you have as a single woman, as a Dalit woman, your ability to negotiate and bargain for, let's say, whether it is hiring of labor, whether it is access to markets, all of this anyway is, constrained. And during the pandemic, the first one where the lockdown was a major issue, we clearly saw that there were differential impacts where women from Dalit communities, single women particularly had, extreme constraints, as a result of which they could not take their produce to the markets or could not harvest their produce. In the second wave, it was very interesting because, it was the illness itself that had completely overwhelmed women farmers. So we had women not knowing really what to do. You know, their farms, the produce was yet to be harvested, or harvested produce could not be sold. So we see a completely different kind of a scenario where the fear of COVID itself had actually engulfed. And we also saw what Poonamji mentioned earlier, a series of COVID widows, the term that is now being regularly used, that young women who are coming to us saying that, we are being disinherited, our lands also are likely to be taken away from us. The other set of issues that came up were also in terms of the distress sales that had to be made both in the first and the second wave. Second wave, of course, far more constraints. But transportation is a very important issue, public transportation. And I think here I would like to highlight how public systems have actually failed women. And these are all public systems. So it is health, it is education, it is the food distribution, but also public transportation. Because once all of these systems were stopped, women said that, their access to private transportation is extremely limited. And this also meant that, there was a lot of distress that was caused in terms of actually having cash in hand. Some examples I would just like to give with reference to cultivators, and then I'll just briefly talk about the other livelihoods, because I think for women, it's not just about being a cultivator or a laborer. They sort of pack multiple activities, multiple livelihood activities. So they're also laboring, they're also cultivating. But a story of a woman who, it was a very telling story of how last year, how the cumulative impact of the pandemic has had on her farming itself. So last year she had to make distress sales of soya bean at a very low rate, something like 3,500 per quintal. And this year, for preparing for Kharif, when she has to buy that same soya bean as seed, she has to pay something, close to 7,000 rupees a quintal. So it's doubled. So the kind of economic sort of impacts it has are also very critical. Now we are also hearing stories of women who regularly leased in lands because that was their only way to survive, but now no longer have the money that is required to lease in lands and other resources that are required. So large number of them are now rendered completely as wage laborers wherever there is work available. And those who did own land are also now increasingly saying that they would lease out that land because they do not have the means to actually cultivate these resources. If you look at the sugarcane cutters, again, and a constituency that Makam Maharashtra is engaged in, we've seen very interesting kind of sharings that we've heard from them. As it is, sugarcane cutters are a stigmatized community, and with the pandemic, you are corona carriers, so we don't want to come either close to you, we don't want to extend any relief to you. So these have been experiences that were shared both during the first wave as well as in the second wave also. Many of them were stuck in their work sites last year. And they are also small farmers. They were, very eager to come back and start their kharif cultivation. But we've seen tremendous impacts of the lockdown last year, which impacted their agriculture, which is primarily subsistence agriculture, as a result of which even that little food that they cultivated on their farms is not available for them this year. So I think these are impacts which are less studied and less spoken of, and are very critical for the very survival of these communities. So these are migrant labor that depend on a number of livelihood activities. Then forest workers, livestock workers, women engaged in inland fisheries, these are all landless women, single women who are now in the second wave, particularly affected because there are, no opportunities for livelihood related activities. Narega, which due to the lockdown last year did not really, start off. But this year, although in, a small way Narega works were started, the fear of COVID itself has actually constrained people back. So I think these are some of the, broad impacts that we see across sectors. But what are the common issues? And the common issues clearly point to a failure of the public systems. As I said, the food distribution, the PDS, you have to have documentation. So if you don't have ration cards, you don't, have access to the free food and all the PMGKY benefits that have been announced. So food security, health access have been very critical, and so also public employment programs. But what has commonly affected all these sectors are two important things, apart from the three that I mentioned, is access to loans. And I think both in terms of microfinance institutions and the havoc that they have caused, I think women across the board have said that these have been, very, very deep-seated impacts on their economic lives. So although a moratorium was, instituted last year, what we saw was that the interest kept piling up. And this has affected them very, very negatively in the second year, because many of these women had actually borrowed heavily. They had actually pawned their gold, which they were not able to release this year as well. And that has created a significant problem. So they have a very clear demand. The methods of recovery have been extremely exploitative. And for women, that has also meant sexual harassment. And these are instances that we have. Schools is another thing. I think online education, again, has had a cumulative impact, and women have suffered because children have not had access. So, mental health, issues of health have already been laid out, so I will not elaborate upon them. But I think, I think if one were to talk about what are the major impacts, one can see that on food security, on health, lack of cash incomes, lack of work, and now in the second wave, the widows and orphans, these are issues that are also very critical. So just broadly speaking, I think COVID, the lockdown, and the illness itself, combined with climate change, because there have been a lot of events, climate events that have occurred over the last year, which have led to failure of crops. These have combined with the pandemic and the structural inequalities. We need to talk about the pre-existing gender inequalities, caste, patriarchy, which in a way the COVID and climate change get mapped onto this. And this has further aggravated. Women have responded. There have been very strong and solid responses, exchange of labor, exchange of produce, exchange of, there have been enormous efforts at the community and local level, which actually need to be taken into consideration at the national level. We've heard stories of how women farmers have procured from other women farmers and have shared their produce. For Makam, what we have done in Maharashtra has, just to conclude with just one or two points, is that our strategy has focused on moving from relief to reform. So whether it is with the state or whether it is with our own interventions, while we did ensure that there were food kits, distribution of food kits, struggle with the government, but also more importantly, trying to restructure. So when we, using this as an opportunity to say that we need to make that transition to a more food and nutrition security based agriculture. So I think the seed support that we extended last year has come a long way this year, because today women have some, I would say capital with them in the form of seed, which they are using this year, at least the women that we are in contact with. So finally, what is it that women farmers want from the state? I think the first thing is recognition and registration, so that entitlements that come by way of documentation are in a way possible to access. Women cultivators immediately seek seed support and market support. Work through Narega is required. And of course, the common issues where children have completely exited out of the education system, they need to be brought back through a number of measures. But in the long run, I think we are looking at how structural inequalities could be addressed, women's land rights, access to other productive resources, and finally, a paradigm that talks about a transition to an ecologically sound agriculture, which values diverse ways of knowing and practicing. And I think here it is women and other marginalized voices that need to come to the fore. So I'll stop here, and if there are any questions, I'm happy to take them. Thank you.
Vibhuti ma'am, please unmute.
Dr. Seema Kulkarni has done an extremely moving, vivid picture of the rural reality that she has projected. And we know there are many responses. Professor Asha Gala from Mumbai University, she has said that it is a very, thanks for sharing heart-wrenching narrative. Are there any inputs or whether any official relief being announced for COVID widows reaching right beneficiaries? And Dr. Mr. Santosh Sharma from Muzaffarpur is saying that this time MFIs have not given any moratoriums. The interest of a moratorium have been calculated in a highly usurious ways, and women have ended up paying much more. And also the Aditi Bharadwaj, Baranwala, she is saying that it is also about the disparity in the wage payment made to men and women, and like a difference of nearly 100 rupees. PDS under FSA could not be provided other than grain, wheat and rice. And there has been exactly 2 months suffering the community has gone through. Focus has not been on survival of the alive ones, but the only thing that too very late is being focused on is a vaccination. So I think these are some of the things that can be taken up in Q&A. And I would like to corroborate what Seema said about sexual harassment for not being able to repay the loan. The same thing is happening in the urban centers, where so many young professionals who are staying on a rental basis, who are not able to pay rent because they have lost their job, whether they are journalists or clerical staff or white collar employees, and they are also demanded sexual favors by the landlords. So I think that is happening both in rural and urban areas. And now I would like to ask Dr. Seema Kulkarni to give a profile of what's happening in the capital city, and also her work with the tribal communities in Chhattisgarh and Jharkhand. So can she just complement what Dr. Seema Kulkarni has told us about the rural reality, and also the Delhi's profile is very, very important, because we are reading so many heartbreaking reports of what's happening in Delhi.
Can you hear me?
Yeah,
we can hear you.
Yes.
Am I clear?
Yeah, you are clear. Yes.
I will share my screen, please.
Yeah.
Ma'am, you want to share your screen? Okay.
Yes, please. Thank you so much for having me here.
Yeah.
It's a privilege to be amongst you all to discuss this issue. I think there hasn't been enough discussion, as Vibhuti rightly said in the beginning itself, although there's a lot of discussion about the shadow pandemic and how the shadow pandemic is as significant as the pandemic itself, but the health pandemic and its gender implications and the medicalization of this whole process, and then the transfer into private hands of this medicalization has huge ramifications, as speakers before me have said. So I won't go so much into the health issues as I will into the situation that people are dealing with in Delhi as well as in Uttarakhand, not Jharkhand, Uttarakhand and Chhattisgarh, and in Chhattisgarh, based on our experience through the Maqam chapters in these states. Now in Maqam, Delhi, we came together as a motley group of researchers, grassroots organizations, and community-based groups that had to respond to this whole emergency of the hunger that we saw and the the sense of not having access to any of the services last year. And hunger became very apparent on the streets when people who were migrant workers came onto the streets. We've seen many pictures of that, of rushing people to the bus stands trying to get a bus load home. I won't go into those details. This time, people have stayed back on the reassurance of the state government. The Delhi government did give people more time to go make the decisions about being in Delhi or going back. They also made assurances that they would not be doing this kind of rigid lockdown, that they would have a more flexible lockdown system. So that seemed to reassure people that, the lockdown won't be for too long and stuff. So people did stay back. Those who had jobs, those who had income assurance and could pay some of that rent, because now the landlords are not, allowing a moratorium on the rent. They're not allowing them to take transport that is more expensive than the public transport. And all these things in lockdown become difficult to access. But Hanji,
sorry, are you sharing the screen?
I wasn't able to, so let me
please try now. Yeah.
Yes. Okay, thank you. Can you see it?
Yeah, we can see it. Yes, ma'am. Please, you can go full screen and then please.
Okay, thank you.
Full screen, bottom, yeah. Yes, ma'am, please. Yeah.
Correct. Okay, so what do we see as the gender impacts of the second wave? We were already struggling with the first wave in Delhi. We hadn't quite got over it. The sections of people that I'm going to focus upon, the marginalized and the poor, had certainly not got over it. Their incomes were less than half. Studies are showing that the incomes have, and especially for women, going back to work was not that simple because there was no work on offer. The worst off were sex workers and domestic workers. And the domestic workers have become in an even worse situation in this second wave because they are just not being given any assurance of whether they will have a job or not. So many of them are single women who are the single earners of their households. And this is they are the primary earners. And in this situation, they're just not able to cope. The circumstances of poverty, of having the children at home, those who could afford to or were trying to get their children into school, now have the children also at home, have no system of support where they can even rely upon the children being in care, where they can get out to look for other kind of work. So their situation has been pretty dire at this time. The other thing is that a lot of them last year took debt. Debt has become a kind of vicious cycle. Some of that debt was from their microcredit groups, but their microcredit groups are also few and far between and have run out of resources in many cases. Plus, they are not lending for consumption needs now because they just don't have those kind of asset base. And then the rishtedari ke jo loan milte the, the relatives and the social support system is also not accessible anymore because everybody in their communities is having this kind of situation. In Delhi, the situation has become much more very different from the first wave, in the sense that in the first wave, the people who were getting affected were typically the migrants, the people who lost employment, the people who were compelled to go out to work and therefore getting exposed to the virus. In this wave, because we see that a lot more middle class and upper class people have got infected, and the spread has been much more in those classes, the pressure on the healthcare system has been both on the private and the public healthcare system. Now, the public healthcare system has anyway been under huge pressure, but the private healthcare system coming under this kind of pressure meant that things like oxygen, things like cylinders and like concentrators, etc., were going at a premium, and the black markets for these became much bigger. So we see that there was a lot of profiteering also going on at this time, hoarding and profiteering. I won't go into that. But what this meant was that those who had the resources could access care for themselves, but and the social capital came into play, and the networks that people had for hospitalization, for getting that cylinder, for getting that ivermectin or whatever medicines were being prescribed. Jugaad became an upper class activity, and getting things done through the people you know. But for the poor, there was no such recourse. And we've heard people saying things like, COVID to ek aur bimari hai. We have a whole string of ailments that have plagued our area. You don't call them a pandemic, but you have TB, you have typhoid, you have cholera, you have dengue, we have the seasonal recurrence of these kind of ailments. But now, because it is hitting every class, because it is at everyone's doorstep, this is becoming the pandemic. And the solution for the pandemic that is being touted is to lock down, stay indoors. Who can afford to stay indoors? We do not have those kind of savings. We do not have those kind of capital resources that we can pawn and get ourselves something. We do not have the shelter over our heads to be able to survive. So this low level of recovery, as well as the deepening poverty in the second phase, has meant that female-headed households particularly have become more vulnerable. And we suspect that there's a lot more female-headed households as men are not taking responsibility. So de facto female-headed households would have increased, and the care burden on women has tripled. They're saying so themselves. We cannot afford to look for work because, Hanji? The women are saying that we cannot afford to look for work because there's already so much work on our shoulders. So they're really looking to the state to be able to provide at least the basic food for survival in their communities. So this is at the Delhi level. There's been a lot of press coverage about the pandemic and how people have survived through it by sheer resilience and willpower. And people are back to work despite the fact that it is still very risky. The markets have opened. Today, the markets have opened and the malls have seen a rush 3 times more than the last time when the lockdown opened, which means that we can expect very soon another wave. There is this is not going to be in the best interests of the people, and the malls have really shown us what we can expect on the streets next. In terms of state services, as Seema said, the PDS and the relief distribution systems have been far from adequate, especially in the Basti areas. And while the state has announced that it is going to be giving rations to those who don't have ration cards, the state government has, there's very little support because of the kind of tussle that's going on between the center and the state. And the consequences of that are most explicit in the lives of the poor, the marginalized populations, and especially on the women amongst them, who have very little access to the care, and the gendered pattern of access to care gets only more accentuated in this situation. I'll take you now to the hill regions and what has been happening there, because that's where we are trying to build a response also. In Delhi, while we've been working on ration relief, mostly through Maqam and our network here, and we are collaborating with the Delhi Relief Collective, which has been active since last year before the riots even. There's a kind of compounding situation in Delhi, but in Uttarakhand, one might have believed that things would be better. It's a remote area, there would not be so much impact, but we are seeing that the pandemic has really started making inroads into the most remote areas. What has happened is that a lot of people who were either migrant labor going back to their homes, or those who were on the infamous pilgrimage, having gone back and then socialized and moved into social circles in their own community, in family and in marriages, etc., have not been able to sustain their own health and have caused the coronavirus to spread with much greater agility, and women's care work burdens have increased, and in the consequence, women falling ill has also increased. While we do not have the statistics to show to what extent women are falling ill, they are falling ill in much larger numbers, are being told कि ये तो खांसी जुकाम है, क्या करोगी? काम तो करना ही है, so they go about their daily work and are not getting the healthcare that is required, primarily because their local doctors are not available. These areas have very little service, especially in the tribal areas. These are the Vanraji areas where our members work in Uttarakhand, and in the Buxar tribal areas, in Pithoragarh, in Udham Singh Nagar, Khatima area. Because of our work in these areas, we have been able to respond to the situation because of the relationship with the communities. And we see that people like the woman here in this picture, Amma, has been talking about traditional health and practices for preventive health. And there are many such people who have been trying to seek recourse to preventive health and build immunity in their own communities. But that is obviously not enough when there are traders and there are government officials coming and insisting on, creating containment zones in their area, on testing, and often even contaminating the public. So that what we've had to do is to talk much more about depending on their own subsistence resources and the denial of these resources causing them greater stress, especially forest and common lands, which are being diverted to different uses. And how communities are even having to depend on the markets is a consequence of this lack of access to their own resources. If we look at the kind of response that has been possible, I mean, you see this picture, which is very stark here, of a containment zone in a village in a tribal area. I mean, there could not be anything more telling than having to put this up in a tribal village, where communities are caring communities and looking after each other, and common resources are often shared. But our teams have been trying to build up a system of care that will help the communities to deal with the pandemic at their own level by setting up care centers in the village. Here we see our community worker, Hira, is going around with their team of volunteers trying to do the checkups, create awareness, debunk some of the myths that have come into the area about the vaccine as well as about corona itself, so that they don't rely on the quacks and the kind of wrong information that's being spread. We've also been working with the ASHA workers. ASHA workers were supposed to get the kits and the PPE kits and the medical equipment to be able to deal with this situation. But as we find in other areas here too, we find that the equipments have not reached the PHC. There is very little preparedness. And yesterday, in fact, we had an SOS call for putting the PHC in order. It would take 25 lakh because there is really no facility and the building is khandar. So what we believe is necessary is not only to attend to the health aspects of the pandemic, but to enable people to subsist in the locations where they are. These are groups of women who have been fighting for their forest rights in that area. This group is a group of women producers of Umang Farmer Producers Organization, women farmers. And they've been trying to keep their production processes going and to be resilient in these times. So they have put in place new institutional processes so that the flow of goods and the order delivery is sustained. There are more details of that available, which I can share if there's time. But making sure that their access to their resources and the continuance of the sources of subsistence as well as of income is critical to how they will deal with the pandemic in these areas. The other issue that I wanted to really flag here is about how do we work with an ecological and subsistence approach to restore what we might call some kind of, hope in the economy as well as in the systems that we have before us. One way that people have been trying to do, you see this poster. This poster is of local vegetable varieties. I'm sure some of you will recognize this in that area. It's called Lingura. And how these vegetables and consumption of these kind of crops, which are locally available, uncultivated foods, will help in immunity boosting. Similarly, in the harvesting the resource from their own fields and having direct access to markets, how can we address that kind of process? Thirdly, in creating awareness about Corona-19 itself and making access to oximeters, to health kits, to masks. You see in this photograph also, people don't have the masks. The Karyakartas are wearing them, and a mask distribution drive as well as oximeter access has enabled them to now set up isolation centers both in Chhattisgarh as well as in Uttarakhand, so that those centers can then provide the care to the rest from the rest of the community, as well as help with hospitalization when that is needed. And along with that, also ensuring that our resilience is embedded in the ecological solutions that we seek. Environment Day was celebrated as a signature of hope that we will restore to ourselves our own ecologies, because that is where survival is best assured. And we really need to look at those solutions of a less a carbon footprint economy that allows us to have access to our resources as well as to the needs of the family as consumers. So these communities in rural areas as well as urban are seeing themselves as producers and consumers, and how best they can restore themselves to better health practices. Thank you. I'll come back with the recommendations in the next round.
Yeah. So thank you, Shoma, for a very, very comprehensive and forceful presentation. You represented 3 states, and your photographs in the PPT, they spoke volumes. Now we come to the most important issue, and I am so thankful to Dr. Swati Rane, so graciously agreed that I don't mind speaking last. Mostly people fight to speak first, but I think she's a very important grassroots activist. As a nurse, she's an alumnus of SNDT and also TISS. She did her PhD and MPH, and she's extremely active in Jana Swasthya Sabha, very forceful person, training the nurses and also filing so many petitions in the court regarding the pandemic, the emergencies created by pandemic on a day-to-day basis. So over to Swati Rane.
Thank you so much, Vibhuti ma'am, and Arjun sir. I'm very thankful that you gave me this opportunity, and it was wonderful to share the platform with such honorable ladies in the field of activism and in social sectors. So it was an honor to listen to all of you all. So I'll just share my slides. Thank you.
Yeah.
You can share it, Swati ma'am.
Yeah, 1 minute. Huh? 1 minute.
Are you able to do that? Okay. Yeah. Yes. Yeah.
Is this okay?
Yes. Yeah. Just go make it full screen.
1 minute, huh, ma'am?
Yeah.
1 minute. Huh?
Yeah.
So I'll be talking on the healthcare workers. So what has happened in second wave is the topic was given to be on overall who are the healthcare workers. Okay, so healthcare workers, to introduce you all, are every person who gives care is a healthcare worker. But you cannot say a mother is a healthcare worker because she is not professionally trained to give the healthcare. So any person who is professionally trained to give healthcare is a healthcare worker, and the person who is licensed to give care, okay, like nurses, doctors, they are licensed people, so they also come under healthcare. But we have in India now, there are many other healthcare workers at the community level and grassroots level, like Asha Thais. Then we have multi-purpose workers who may not be licensed or who may not be even considered as healthcare workers on paper, but they are doing phenomenal jobs. So now if you see, healthcare workers definition has to be redefined according to me, and COVID has brought this issue very strongly. The most important thing is that healthcare providers are majorly women all over the globe, and in India, at least 50 to 60% female are the healthcare workers who are there. And as the gender issues we all know, this is a nice pic which I got from Asha George, where she has put this pic as violence against female workers is just tip of the iceberg of gender power imbalances. And here she is very nicely shown how the gender inequalities like lack of space and opportunities are there, lack of recognition, unpaid labor, low and unequal pay, precarious work environments, lack of protective measures, insufficient data, which is there throughout all the ladies or all the females who are there, from the doctors to the sanitation workers. You can see similar type of things in the gender equalities. In gender biases also, you can see that there is a gender data gap is there. Gender resources are poor. Gendered occupational segregation is not there. Gendered discourses, gender decision making. So these biases which are very much existing from the top to the lowest lady who is working. Then the gender power relation, who decides what is value, who does what, who has what, who is known. This all is coming up because of COVID. Otherwise, these things were very nicely wrapped and kept under the carpet for many, many years. So it was fortunate that, we got this policy action paper by WHO, which is closing the leadership gap, that is gender equity and leadership in global health and
was released yesterday only. Yeah.
Yes, and I was fortunate that it was shared by a very good friend, Kavita Bhatia and Vibhuti ma'am, and it was honor. It was such a great honor that we could see this thing coming so much through the agencies like WHO and WG and GHWN, that this is now there, and we have to take it forward. So the key findings on gender equity and leadership in global health and social workforce, which is delivered by women and led by men. And definitely the issues are gender leadership gaps are driven by stereotypes, discrimination, power imbalances, and privilege. Women's disadvantage intersects with and is multiplied by other identities such as race and class. Global health is weakened by excluding female talent, ideas, and knowledge, which we will see, like in task force, we don't see any lady or any nurse or any Asha type, but we see all the doctors and males. Women leaders often expand the health agenda, strengthening health for all. Gendered leadership gaps in healthcare are barriers to reaching the SDG goals and USCs. So this is very much prevalent, which was known to us, but this policy action paper has really brought it on our face. So the COVID-19 pandemic, if you really see, women have provided a lot of care. Okay. We have seen that community health workers, Asha Thais, nurses who are almost 80 to 85% are nurses are females, and doctors also who have really gone out of the way to provide care, but they have not been there in equally in taking the decision on the table. Okay, and that is what we are seeing today. The representation is not very much different in global health and national health scenario. If you really see that women are almost 70% of the global health and social workforce, and it is estimated that they hold only 25% senior roles. Okay, so if you see even in the Fortune healthcare CEOs, they are only 7.5%. And if you see the nurses, they are 90%, healthcare workers, 67% females. If you look at the ministers of health, just 31% at the global level. Okay, deans of public health and medical school, just 28%. Executive heads and board chairs are just 27%. World Health Assembly heads and delegations are just 23%. So if you see, if the bottom is so heavy, that is the nurses, the healthcare workers, the long-term caregivers are almost 90%, 67%. But the decision-making, if you see, is less than 30%. Okay, and on the topmost, if you see the private healthcare, it is just 7.5. So we are invisible completely. And that is the reason we can see there are so many gender gaps. Coming back to India on the national health aspect, if you see, in the present day, women healthcare are not just doctors or nurses, but the participants across the entire spectrum of healthcare, which I explained, that is Ashatais, or again the soul of India, who are reaching to each and every village. Okay, and also the CEOs and the directors of the healthcare organizations. So in India, women are almost 50%. Okay, in the healthcare workforce, but we are negligible or invisible in the decision-making powers. You can see the midwives and the nurses are again, almost 80%. So all these things show us a very sad story. As we go down, if you see the sanitation workers, most of them are ignored, and you can see here most of them are female employees. So if these people are not catered to, what is going to happen to the healthcare system? So almost, if you see the sanitation workers, the chairperson of National Commission of Safai Karmacharis, Mr. Venkatesan has said, despite the high number of deaths among the Safai Karmacharis due to COVID-19, the states have not come up with a uniform policy for the welfare of these workers. So they are not existing. Their work is very much needed, but their care or their well-being is almost invisible. Okay, and here if you see during our ground level work, when COVID started last year in March, that time all these Safai Karmacharis in the hospitals are all on contract workers. So they were not even told what is COVID. They were not even given PPE kits, because PPE kits that time were not even reaching to the nurses or the doctors. So these were the last people. So they were working in such a dangerous work environment, and they were carrying that same thing back home. The data provided by the 3 municipal corporations of Delhi has revealed that the sanitation workers comprised, that is 16 of the 29 dead employees in South MCD, and 25 of 49 in North MCD, and 8 of 16 in East MCD. In all, 49 of 94 municipal employees who died were sanitation workers. And they never had any safety gears, they never had any training, they don't know what is COVID, they don't know anything. But now, with COVID going so down in each person's house, people have understood what is COVID, but still the proper working environment is not given to the Safai Karmacharis. Similar issue is seen in Tamil Nadu also. In July last year, there was a report that 6 Chennai sanitation workers had succumbed to this coronavirus. So this was at the state level. And if you look at the union level, it is a very sad story. The absence of data was acknowledged by the Minister of State, that is Ramdas Athawale, in the Parliament in September last year, where in the response to the questions by MP Bhagwat Karat, he said, hospitals and dispensaries being a state subject, no data is maintained by union government about Safai Karmacharis, which is very, very bad, who have died due to the health and safety hazards. Okay, who are giving their life to cleaning the hospitals, taking care of the patients. So now they are asking them the compensation, at least to give 25 lakh. Even that is not yet been finalized, because commission is not a statutory body and it has its limited scope. So the problem is, because commission is not it is a non-statutory body. It even can't go to the Supreme Court to get some feedback or some assistance from the state. So this is a very poor situation of the state. Coming to the nurses, nurses have been the highlights in last year and this year also. Nurses were not known so much, but COVID has shown the nurses and shining in everybody's eyes now with their problems, because nursing issues were never being given any importance. So when COVID literally started, that time we had fortune that Swasthya Abhiyan had online meeting with that times Mr. Pardesi was the municipal commissioner, and we had asked them these questions, that why don't you take nurses in the task force? Okay, this was on 18th April 2020. And on the meeting, he said it is a very good suggestion, because nurses are the one who are 24/7 in the hospitals and taking care. So nurses should be in the task force, but still it is just a good idea. But we have given 2 letters to the Chief Minister related to the issues not only of the nurses, but all the healthcare workers, from doctors, nurses, and other healthcare workers. But these are not even being considered, or we have not been called for discussions also, which again led us to do a study. So with Sati, we did a study for the Maharashtra level on the nurses, and again we tried to generate some data so that we can show this to the government, that these are the issues which we are not saying, or it is not our feeling, but it is actually happening, that 76% of the nurses said that they are overworked. And it was actually overworked because the way COVID happened last year and this year also, the workload has increased tremendously. Second wave has in fact brought worst nightmare for the nurses, because their pay, which was given to the nurses last year, has been cut, okay, by 50%, because now they have brought in contractors who are not directly taking the nurses to the hospital, but on contract they are taking, and they are making their own contracts, which is not even given in hand of the nurses. It is just verbally told. So today the nurses are getting 50% cutback after working almost 12 hours in that PPE kit. So the issues have become very bad for nurses, because the working conditions have not been improved. Their pays are cut. Vaccinations are not given to all the nurses. Okay, only the public health nurses are getting free vaccination. Otherwise, private healthcare, we got the data that some of them are paying, but they have not been. They have highly been asked not to reveal the data. Okay, so much of pressure they are having. So there are no quarantine facilities. Shortage of staff still exists. And the COVID death, I mean, the nurses, the martyrs, if you see, within 3 months, we have got 62 deaths. And last year it was almost 8 months, we had 62 deaths. And all these deaths are young nurses below 40 years. And it is very sad situation. Coming back to ASHA workers, today itself, ASHA workers in Maharashtra have started their strike, because again, they are not being given their demands, and ASHA workers are working without proper safety gears, without proper payment. Almost, if you see across Maharashtra, 570 ASHA workers are infected, and they are not even given proper working conditions or quarantine facilities or treatment facilities or even vaccination. And most of them cannot get vaccinated because they don't have those mobile fancy phones where they can, register themselves. So most of the ASHA workers are facing a lot of problems. They are going through a lot of physical violence, abuse, because they are going to people to get the data or to explain them. And people don't want them because they feel that if they come to their houses, they may get the infection. So they are, being literally battered from both the sides, from the government and also from the community. So if you see, overall, ASHAs are really suffering a lot, and there is nothing for them. There is no system for them, and only strike and negotiations and talking to the government is going to help. And the worst part, what the ASHAs are doing now, is that they are all the extra work which there should be community health nurse. It's been put on ASHA's head. So the nurses are doing the clerical work in the hospitals, and ashas are doing nursing work in the community. So overall, if you see, there is no proper job role or job orientation at the public health level. And public health, if you see, most of the people who are there in the public health department are male doctors. Okay, even the administrators are males, and they are medical people. There are no nurses there in the administration, and also at the state level, if you see, we don't have any say, because all of them are men, and they are doctors who are handling the things, and they are overloaded with work. So it is a bigger tragedy. And also the politicians, most of them are men. So all the female issues, okay, they cannot see it. So this time we had approached to the political parties, women leaders, like in Maharashtra, we had gone to Dr. Neelam Gore and Vidya Chavan, who at least, understood that why the working conditions should be are important for the young nurses or young ashas, why it is important for their safety and security. At least they could, allow us to give our suggestions. Now, coming to the doctors, almost we had the deaths of the doctors had increased. Okay, so this year we had 624 doctors dead as per IMA versus 748 doctors last year. This is not even a year. This is just 3 months. We have lost so many doctors, and even in there, doctors are getting a lot of abuses and violence. They are getting a lot of hittings from the patients because the patients are dying. And here there is no gender issue. Mostly the men are getting the abuses and hittings and the violence and harassment. And most of the women doctors are now really fearful of their life to come on the duties with such type of unsafe work environment, but still they are coming, and the workload is humongous. And because of the poor infrastructure and facilities in the nation, like we all know, oxygen was a big issue. Injections and drugs are a big issue, and all these issues, because the state and the nation is not, the center is not prepared, all the brunt is being taken care by these doctors and the frontline workers. And with this, I end my.
Okay, so now I think the issues which are being discussed in the chat box, I think they have been resolved, because all the 5 speakers have taken care of the points raised by the participants. Now, can I give like 2 minutes to each one of you to focus on way forward? And yeah, so I think because we have, I did not curb you when you were making your PPT, all 5 of you got ample time. So now in 2 minutes, if you can focus on. So we can start with Renu. Yeah.
Yeah, so I think the most important thing, which we've been saying for so many decades now, is that we need to invest more in healthcare.
Yeah.
I think that is fundamental, and I think that this has been widely recognized now. So far, it has been the activists, the Swasthya Abhiyan, who've been saying this. But now I think the stark reality is that greater investment in the healthcare is required and is critical. If it's not there, then, we've seen the consequences. So infrastructure has to expand, human resources have to expand. And I think also I want to make a point here that governance has to improve. Health governance has to improve, accountability has to improve, and accountability, answerability has to improve. And I think citizens, all of us, have a very, very strong and critical role to play here. And I think what is important is that we consolidate ourselves and speak in one voice. I think solidarity is required, and we need to come together, more and more of us across our sectors, across, to create alliances and to demand that kind of accountability, which we've already been doing actually. and very important aspect. And now, as you can see, I'm talking very generally. I'm not talking about the gender, or the women's, because I think it's of course women's issues are important, but I think there are these larger issues which have to be reined in. And one other point that I want to make is that when I'm talking about health governance, I'm also saying that the private sector exploitation has to stop, has to be controlled. And this is not the forum, we don't have the time now, but there is ample evidence of how the private sector has misused, women, women's health, and profiteered from women's health issues. But I'm not going into all of that now. So this is the point that I wanted to make, and I want to re-emphasize my point about decentralization, decentralized local planning. And I think we have to learn from BMC's experience that
that's what I was going to say.
the whole thing about decentralized planning, but with coordination. So it can't be just a laissez-faire sort of a policy. And resources are extremely important. You can't expect communities to be putting in their resources and doing, participation, community participation. Resources have to come from the state, and communities have to decide where and how these are going to be spent. Let me stop here now.
Yeah, thank you, Renu. Now, Poonam, what do you think? Yes.
Yes, thank you, Vibhuti, and thank you, Renu. So I reiterate Renu's point about increasing investment in the health sector in the first place. I think unless we do that, nothing else is going to happen. I think for the next phase, government needs to work on cash transfers. First phase, they gave about 500 rupees. That was a very small amount, but it still did go into the Jan Dhan accounts of women. I think we have been now asking for 2,500 rupees per month till the second wave. They've already said till November they're going to be giving PDS free. Regularization of ASHA workers on government minimum wage rate. I mean, if you go by those standards, then an ASHA worker should be getting about 13 to 18,000 rupees per month. And I think during this COVID, they have been the lifeline of this country. I think if they had not been there, I mean, let us just imagine a situation. So that's going to be one. I think we need to also do targeted vaccination drives for women, because without that, this country is never going to be prioritizing women's vaccination in that sense. I feel under NREGA, we need to create support services for women of creche and of providing free tiffin to families who get affected by COVID, because women become the major caregivers, and very often they are the ones who are affected and still looking after the family. Last, I think data, because the government is somewhere trying to constantly keep the data to themselves. Unless we have a dashboard, I think we have the best minds in the country who can analyze data. Data analytics skills exist, but the data is not coming out, and that's why the policy response is also very, very skewed. So those are my, thank you.
Very, very sharp and pointed suggestions. Now, Seema, what would you like to say about the women farmers and also the rural sector in general? Seema, Dr. Seema Kulkarni.
I think I, of course, did in my presentation highlight some of the things, but as I said, we also should look at this pandemic as an opportunity to restructure and reform. And I think from the women farmers' point of view, one of the long pending question of recognition is very, very critical. And I think it was, both the waves of pandemic clearly sort of showed us how entitlements simply did not reach these women simply because they are completely invisible. So I think that recognition is very critical. And as we've been arguing, registration also. In whatever capacities, as engaged in multiple livelihood activities, I will not reiterate some of the demands that have come by way of food security. We've already been speaking of universalization and expanding the basket. So not only are we saying universalize, but also it should not be limited to wheat and paddy. And that also closely links with the kind of farming that women are doing, women and small and marginal farmers, because here then we talk about the procurement. So, we should not have policies that focus on wheat and paddy, but look at diversity. So millets and, various other pulses should also become part of the basket, which then also increases the potential for women farmers to be able to sell their produce after their own subsistence needs are met. A sort of imagining of the Narega, where, of course, it talks about asset building, but how could we sort of, reimagine Narega, which looks at asset building of these small and marginal farmers towards a more ecologically centered agriculture. So I think that's one of the critical issues that we should be talking about. And of course, I mean, a very strong emphasis on land rights, both by way of inheritance, but also looking at how community rights could be strengthened. So I think individual land rights for women, yes, as part of the inheritance that they deserve, but also community rights and extending these community rights, I think is going to be very, very critical. So, and other productive resources. So it's, unfortunately, all of this is structured around the right to land. So access to credit, access to various other programs, agricultural programs are also linked with right to land. So I think we need to de-link some of this and ensure that every rural woman engaged in livelihood activities needs to have this access. So I think, one needs to look at the broader framework, and within that, how we could support women farmers. But of course, in the immediate term, they require cash transfers. We are talking about 3,000 rupees per month, at least for 3 months. We are also evolving certain calculations that for 1 acre of rain-fed land, if women are supported with seed and basic agricultural inputs of organic manure, there is a possibility of making that transition. So relief can actually transform into or create a pathway for long-term sustainable options, both in terms of livelihood and knowledge.
So organic manure by the community, they would make
yes,
it.
So
providing
yes. So there is a bioservice center that we are talking about, which again is, in a way propelled by the local communities, the youth which are exiting agriculture, but they need employment opportunities, which can be in fact, developed around agriculture. So those are some of the immediate demands that I can think of.
Thank you. Thank you. Now, Dr. Seema Kulkarni, what would you like to say? Yeah. Also, the issue of vaccination in rural areas.
I'm very happy to follow on Seema's points, because there's a lot of overlap. She mentioned the issue of land and land rights. Along with that is the issue of access to the services to make those resources viable, which brings us to the point of the nature of policies themselves, how those can be oriented to address much more the needs of small producers, small farmers, and particularly of women, through pooling in of resources. For instance, grain banks, food banks, kitchen gardens, food processing units. These all need institutional credit access. It need not be a credit alone, but investment in the revolving capital. As I put in the chat, there are many examples where a dose of working capital has enabled these institutions that women have created to survive and sustain and become self-reliant even in the period of the COVID. And just as we did in terms of the digitization of the microfinance institutions, a lot of young people came into that process at one time in the 90s. Similarly, for the decentralization of food processing, for the decentralization of a lot of the agricultural activities which are now being seen as part of big agri, it should become local. It should become much more decentralized, closer to the place of production, so that the revenues go back to the community of producers, and that revenue also helps them to increase their consumption expenditure. The other point I wanted to make was about how we view subsistence economy itself. You know, this whole thing about enoughness, this drive for a neoliberal economy where every comfort is related to consumption expenditure, is a myth that is about this bubble will burst, and it will burst into our faces. We are seeing it bursting at the cost of precious lives. So this whole thing about subsistence and managing with our own resources, with the Sasta Tikau solutions that are locally available. I mean, it sounds kind of very basic, but we really need to go back to those kind of solutions that enable us to survive, subsist, and flourish in these kind of practices. In terms of the policy shifts, therefore, we need to look at those policies that are actually exploiting farmers and producers in every sector at the cost of a market profiteering system, and invest in the local production systems. So that's the first call. The second is things like, you know, in the urban areas, rations. We are distributing rations as a relief activity. Those infrastructures of the state and of CSR should invest in community kitchens, care centers that release women from this burden of caregiving work and allow them to give care in a way that they can also enjoy it. I mean, it's become such a pressure for them right now that they cannot even think of the enjoyment of a caregiving role, you know. So these kind, and the other thing, in Delhi particularly, we find that the community kitchens are seen only during the relief activity. Whereas in Bombay, there is a culture of the community kitchens. There are dabbawalas who are delivering, etc. I think that has to do a lot with how feudalism is.
Under pandemic, dabbawalas have started a kitchen. It's a huge area. The BMC has given them. They are providing lunches.
This is an employment opportunity. If the state, and especially Delhi Sarkar, if it is saying that it wants to promote local solutions, they can set up these models of community kitchens where communities themselves are employed to give provision of services that they need from their own kitchens. It doesn't need to be at a very large scale. Yeah. The other thing that I wanted to say is that I'm totally in agreement with the points raised about health infrastructure investment. I think there is a non-negotiable there. The universalization of vaccines is a demand that we should definitely make, because there is no getting away from it. The community rights issue that Seema raised is something that I have been talking about for 10 years and more, and it is something that we cannot do without. But the whole issue of the state and its own policies taking away these basic rights needs really to be contested through the mining, through the diversion of the forest resources, through the kind of investment in infrastructure, and defense, even in these times, I mean, is a ridiculous story. So food as a necessary, non-negotiable human right, and the infrastructure investment from state bodies and from CSR would be a priority. Health infrastructure is a priority, and rights to their own resources for communities to sustain and flourish. Thank you so much. It's been a pleasure to listen to all the speakers today.
And also, I think vaccination should not be online. There should be door-to-door or a community-based delivery.
Santosh made that point very
low. Okay. Now, last one, Dr. Swati Rane. Please.
Thank you, ma'am.
Yeah.
As we all are fighting that we have to build the public health system very strong. We cannot depend on private healthcare, because we have seen in COVID times that private profiteering is their aim, and we should not allow them to do it, because it is not healthy for the country and not healthy for the community, and not even healthy for the people who are working, the healthcare workers. Because if you're aim is profiteering, then the well-being and working conditions will never be taken care of. So that should be the prior importance to be given. Like we should develop a good public healthcare, robust public healthcare system. And in that robust public healthcare system, we should create diverse groups of leaders. They should not only be from the medical fraternity, but they should include from all the various other disciplines also, like nursing or epidemiology or social work, medical social work. You can say also from the groups of people who are there at the ground level, who are working as farmers or the real users, so they should be there, the patient should be there. So all these people, there should be a good diverse group for brainstorming on what type of resources, because India is a large country, the terrains are different, the need of infrastructure is different, the diseases are different as per the terrain. So we cannot have a 5-star super specialty hospital in Uttarakhand where you never know when it is going to have so many other climatic changes. So I feel that that we need to have engineers with us, we need to have architects with us. So it should be a very diverse group in health. Health should not be only for the face of the doctors or nurses. So now health should have many other actors into it. Then also at the policy level, we have to completely enforce the policies on the healthcare workers' well-being and healthcare workers' working conditions. So the working conditions and the practice work environment will only be good if they have proper policies for their safety. That is the most important thing. Then about their payments, you cannot keep on people on contract for years together like Asha or nursing people for years together. So you have to also bring in the shortages. Vacancies should be filled. You cannot keep on keeping the vacancies, because healthcare is not a place where you can keep vacancies. Otherwise, getting technology. Okay, so today there is no technology, no digitalization in healthcare and public healthcare. So that should be the robust thing what we should do. Telemedicine is, we have seen that private healthcare has within few months, started doing telemedicine. Okay, so why can't the government do it? Then the drugs, okay, the proper policies for the drugs and the rates of the drugs should be managed. Then comes is the real thing about the maternal and child health care policies. And who is going to work? What type of skills are required? Today, you're asking ANMs to come and give care to the patients in the hospitals, which is not acceptable. They are not trained for it. So you cannot do this type of skilling, as per your requirement. And who is going to do the decision maker? The decision makers should be the actual owners of that profession. So today, the national bills, what you're passing for the nursing or the skilled workers, they should have their autonomous body. You cannot decide at the center what you're going to do. So that let it come at the state level. Let the state decide, and the union leader, the center should only be there to help them. Okay, so it should be more of decentralized things should be there. Then I would suggest very much important thing is health should not be related only to the medicine. Water, food, sanitation, the environment, all should be the aspects of health. Okay? So all the things when they come together, and preventive healthcare is the most crucial thing. Primary healthcare should be very strongly done. So when primary healthcare is strongly done, then tertiary level you don't need. But today we don't have primary health. We don't have primary healthcare. Okay? So even for a small vaccination, it is so difficult today. So all these things, I think a whole transformation is required in healthcare. That much I can tell you. Without that, it is not possible.
Okay. So thank you very much, Dr. Swati Rane. I think all 5 of you have given a very, very comprehensive, holistic picture. Dr. Ms. Renu Khanna, with a public health, had a very long experience in public health sphere. Poonam's long experience in the gender as a gender person, and also grassroots level activism combating gender-based violence. And both the members of Maqam both the pioneers and mainstays of Maqam, Seema and Shoma, they gave a very strong picture about very important and a picture about rural, because generally rural in the first phase, there was hardly any discussion on rural areas and also women farmers. And spokesperson of a healthcare workers, Swati, she also took a right from doctors to sanitation workers. She has covered that. And I think we got a very, very important insight. And I think it's very important discussion. Historically also it's very significant, because the UN has just yesterday declared that global health is losing out on women's talent, perspectives and knowledge, and which I think we got in today's webinar. The World Economic Forum also estimates that it will take 257 years to close the gender gap at work if the status quo is mentioned, but none of us are going to allow that. We must ensure that economic recovery prioritizes women and girls, underpins an inclusive future, and ensures world is prepared to withstand the next crisis. So the government must ensure money, stimulus effort, social protection schemes, and also we need to have close the gender data gap, strengthen monitoring, evaluation, and data system to support more effective public policy. The governments must also reduce the burden of unpaid care work, and also support the better childcare facilities, whether it is in MG-Narega or in the industrial sector. And I think recognition, reward, and redistribution of care work needs to be done. We have to challenge the gender norms, and we want a more, if you want a more better harmonious world, which is gender inclusive, I think it's very important. And as the UN director also recently said, that we have no time to waste. The risk of infection cannot be overstated. Refusing to economically support women and girls will not just set this recovery back, but it will leave our economies more vulnerable to future shocks. A blockage in the pipeline stops when women entering the leadership in equal numbers to their male counterparts. And this is what the UN has said. So I think we need to make the special focus on gender responsive budgeting adopted by nearly 84 countries recently. And we need to be more, the focus has to be on socially marginalized race, as Renu Khanna also said, that it's not only gender, but also marginalized race, class, caste, ethnicity, age, ability, sexual orientation, and identity and gender. So I think that's a very, very important that this kind of inclusive perspective, all the nation states will have to take. And I think we can make the beginning, because in India, we have a very articulate and very vociferous, fearless women activists in the country who are ready to take this kind of a challenge. So I think it's with this, I would like to once again thank all 5 panelists for their extremely well-documented and analytically rigorous presentation. Over to IMPRI. Thank you.
So thank you so much, Vibhuti ma'am. And with that, the closing remarks of Vibhuti ma'am, I would like to thank all of you for joining us here and also on Facebook. There are some comments also in Facebook Live, but mostly about the deliberation, not any question per se. So thank you everyone for joining here and on Facebook Live, and on behalf of Gender Impact Studies Center, IMPRI Impact and Policy Research Institute, we thank all of you for joining us today on this panel discussion on gendered impact of the catastrophic second wave of COVID-19 pandemic, way forward towards combating the third wave in India. And we are so thankful to all of our panelists for joining us today. Seema ma'am, Swati ma'am, Poonam ma'am, Renu ma'am, Soma ma'am, and Sona ma'am could not join, but she's giving me a call. I will talk to her. Right, so we are thankful for all of you for putting your effort, your energy toward this very important topic. And not lastly, firstly only, thanks to Prof. Vibhuti Patel ma'am for her zeal and enthusiasm towards this subject, and leading us and directing us towards this very important deliberation. I wish you all very good health.
There is a very popular demand for PPT as well as recording. So just say that it will be available.
Yes, on the event page, on the below you can see IMPRI India event gendered impact second wave. You'll just write gendered impact, then you'll find everything IMPRI We will put all the things on our event page and on our YouTube channel, Facebook, everything will be there.
And many participants have also asked for PPTs, which we don't.
PPTs we will
upload
there.
Yeah.
PPTs we will upload there. So thank you everyone. Please take care and have a nice evening.
Thank you.
Thank you so much.
Very much.
Thank you.
Bye-bye.
Thank you so much.
Thank
Bye-bye.
you, Vibhuti.
Bye.
Thank you, Arjun.
Yeah.
It's a very stimulating session.
Great to be with friends. Huh?
I think all of us collectively made it. I think 5 of you were really super, brilliant.
Were marvelous in stringing it all together.
And each one made such a studied presentation. No one was just casually talking. No, all of you really prepared so much and came.
And it happens very rarely on such a topic. So thank you everyone and congratulations.
Thank you. Thank you so much.
Such studied
best.
presentation.
Bye.
Don't feel like leaving so many
I
people
know.
you want to be with.
Correct.
I will share the video over WhatsApp soon.
Please take the photo also.
Yes.
Yeah. I'll share photos also with all.
Okay.